No problem.
Okay, so the
Thank you.
same approach as we use the introduction, the name, age, or you have to, because when you come up to the history taking, usually patient is conscious to you, but he can explain you the previous history. Maybe he said yesterday I have been collapsed, yesterday I fall down, yesterday I had blah blah problem, so or a few hours ago. But at the moment when you meet the patient inside in the room, he is okay. Okay, but in hypoglycemia situation is a little bit different. We will come up with that. Okay, so introduction, you went, Sam, you have to go for open question. What have brought you to here today in the hospital? Or the how can I help you? Empathy, you have to show it, and then next question, and then again you have to show the empathy. But sometimes usually the things is very visible when you are coming up to the approach. Okay, here you can guess what was happening. Either the patient has dizziness, or maybe goes to vertigo, or maybe it goes to the event approach. Anyway, you can follow both approaches, no problem. If you follow both approach in a patient with present with dizziness or vertigo, no any problem. Okay. Sometimes people say you need to confirm that. Okay, what do you mean? Did you lose your consciousness when you fall down? Okay, if it's good if you ask a question. If you don't ask, no problem. Everything will be visible when the event approach. Okay, so in case the fall, you can follow the event approach regardless of the patient lost consciousness or not. Okay, so it's not really necessarily that you must follow the power if patient complain like I have feel dizziness, the everything will be spinning around me. No, it's not necessarily. Okay, you can follow the event approach. Okay, so the question for before event, okay, it's clear, I think, for you guys that from here to till the next open question, and then you come up from in place of adipara, or the for the pain in Socrates, we follow, but here we follow event approach. So it's divided in three parts: the before event question, during, and the after. So what were you doing when this happened? Where did this happen? Any witness? You need to ask him. Okay. Any preceding symptoms like any headache, vision problem? Okay, you need to ask here. So this is about the symptoms. These the cardiovascular, any chest pain, heart racing before event. For example, the patient with the hypertrophic the cardiomyopathy, or the patient with the Brugada syndrome, or the heart block, you might have the heart racing, or might have the problem with the heart. You may be complaining of chest pain, so it can be clear when you ask this question. Vasovagal, the patient will feel dizziness or lightheadedness. So it's like patient will say, when I wake up from sitting position, standing, or sorry, the patient will complain like dizziness, the lightheadedness when patients say I was walking or sitting from standing position, also in the same like ortho static or hypertension and vasovagal, both possible. So the management also the same in both. We will discuss in next slide. Okay. So in this case, you will hear about these complaints. So you will follow. This is involved in syncope. Okay. So we will discuss in syncope slide. So I mean, these are the things which you need to ask. And if he said, and you ask dizziness or lightheadedness, so it might goes to orthostatic hypertension, or maybe go to vasovagal. So these both are relevant to syncope. So anyone can tell me about syncope? What mean by syncope, guys?
Syncope means vertigo or sudden loss of consciousness.
Transient loss in consciousness.
Yes, very, very,
Temporal loss of consciousness.
yeah, temporary in within maybe 1 or 2 minutes, like this, not very long. Okay. We will come up the way syncope causes in the next slide. We will discuss. Okay. During events, excuse me. Okay. 1 second. Yeah. Next is we are here in during events. You will ask him, did you lose your consciousness? Did you wait or swallow yourself? Any incontinence or tongue beating? For example, a patient is seizure. So in this case, did you have jerky movements? It's also relevant, but there are two kinds of seizure. One is non-epileptic, is called psychogenic. However, both are nearly present same features. So in this both cases, we need a very important assessment and the similar assessment, but once come negative, what we call EEG. Okay, will come up in the next slide. How long were you on the floor? If the patient was on the floor, if he said he was, you need to ask him questions. So these all questions relevant to station. Maybe you don't need to ask all questions. Okay, you will find the difference in the hypoglycemia when we come up. But for the fall and the seizure, this approach exactly you have to go same way. Okay, after events, you told me you need to ask him like, you told me that you fell down. Were you able to get yourself up off the floor? Means you, any injury you sustained, or did you injure yourself? So after that, better to go with the eyes, okay? Because you need to see what is the opinion of the patient. For example, what do you think what was the cause of your symptoms? So patient can tell you, maybe because of medication, maybe patient said he thinks because he had a stroke a long time, he is not ambulatory, etc. Or he has a visual problem, like anything like that. Another is concern. So for example, patient A has a Brugada syndrome history, so he can say, I'm worried maybe I will die soon, or my father is dead earlier. So he can tell you, so this is maybe concern. So, or he can say, maybe I had a Brugada syndrome, as my father had it, and he died earlier. So this he can tell you, and you can guess it. If the patient present with fall, or the syncope, or the seizure activity, maybe you can confirm here. So these questions you can ask earlier before systemic review would be better. Okay, expectation, you will ask him, so what do you want to expect from me? Okay, what are you hoping from us? Maybe patients say, I just want to get well or anything. Then you go systemic review, etc., the same as usual. Then summarize, then past medical history, social history, consultation, diagnosis. The most important, we will focus on this station, today's webinar, the management plan, which is very important. I believe that the management plan, which I am going to tell you, will be a lot different, and that is according to the guideline. So we will discuss in next slide. So this is about how you approach in patient with fall or the seizure activity. Okay. Fall can be syncope, can be another cause, can be drugs, etc. We will come up to next slide. And now we have another slide. This is confused patient and hypoglycemic. So this approach is a little bit different. We don't follow exactly which we follow in for the falls or seizure, because if you follow that one, that wouldn't make sense here. Why I'm saying, because confused patient doesn't mean the patient has lost his consciousness. If you ask a patient, did you wet yourself? It's just like you're joking with them. Did you swallow yourself? What? Do you think so confused patient can do that? A patient, the most of patient, the station which came in, one of my colleagues told me, it's well like the patient was walking, but he doesn't listen to, he's unaware of the environment at all. Patient can communicate, but he doesn't understand what's going on around. So those questions we will come up to in present combine. Okay, first of all, you will resuscitate this patient. For example, you come up in the when you get into the room, you came up to the patient. Hello, my name is Dr. B. I'm ED registrar. May I confirm your name and age, please? Patient will not respond to you because he's confused or she's confused. Okay. Maybe she's walking, maybe she's sitting, but she doesn't respond to you. So what you will do, and one more thing I want to tell you, in the exam, in the case, they will mention that patient is confused, so you can get an idea. When you get into the room, patient will not responding, then you will ask nurse, could you please check his or her vitals and check the blood glucose level? Please let me know. Once the nurse will do, the nurse will let you know what is the glucose level, okay? So, for example, if nurse told you that the glucose level is less than 4 millimole, so this is the guideline that if the glucose level is blood sugar level less than 4 millimole, that means it's hypoglycemia, okay? So you'll ask the nurse, so could you please tell me the confused patient is conscious or unconscious? Consider as conscious or unconscious? Anyone?
Conscious.
Yeah, conscious.
Yeah.
Yes, conscious.
That's correct. The patient would be conscious. So what is the treatment for the conscious patients according to NICE guideline, guys?
You give them some sugary drink, juice or something like that.
Oral.
That's great. Yes, you need to give orally. Either you give dextrosaline or you are going to ask the nurse to give her a juice. Fortunately, in the exam, they told me there was a juice. Wow. So he told me that when he gets into in the room and he finds when the nurse told him that this patient has low sugar level and he saw on the window, near the window, there was a juice. So it also gives idea that this patient needs juice. Okay, so that's great. So you need to treat patient orally with either with the glucogel or the juice. Okay, not with the, you don't need to take IV access. Okay, once you resuscitate this patient, okay, give the juice, then you come up to the patient and introduce yourself. I'm sure this patient will respond to you. Here, the outcome is checking how you go with this patient. The important point, your resuscitation before you go for the collecting data. So almost a 5 score, you will get it on this point. The rest, you will go for collecting data. So you will introduce yourself, then everything will go the same. Like you will say, Miss Lena, you have been brought by your colleague, if she's brought by her colleague or husband or by ambulance crew. You will tell her that with low blood sugar level, and we gave you some juice or dextrose, since then you're getting better. How are you now? Okay. Are you comfortable? Are you feeling better? You can use any of the sentence. If she say, yes, I'm okay, then you need to do a cognition test to make sure that patient is fully conscious, right? Means it's not confused still. So you'll ask her, where are we now? Or where are you now? And maybe she will say, in a hospital, who am I? Better to ask, okay? Then you will go for the data. You will say, I need to collect some data regarding your low sugar level in the event you had it or you were confused, to better understand what was the cause or to understand your health. Is that okay? Then you come up the approach. but here the approach is very short. Do you remember what had happened to you today? Like this, if you ask, what were you doing when this happened? Maybe she can tell you something. Any injury you sustained? Or did you injure yourself? Have you had similar episode before? So that's gonna give you ideas some about maybe she had similar problem before, or it's a new. If the new, then the likely the drug cause. Okay, new likely would be the drug cause. Maybe her medicine recently changed, or new addition in her medical or drug chart. Okay. So can you please tell me, will you ask her here, did you wet or soil yourself? Do you think it's logic to ask the question? Or is it logic to ask
No.
this patient, did you lose your
It's not related.
consciousness?
Yes, sir. Of course.
Do you think it's
We
logic
have
to
to
ask?
ask witness.
Loss of
Witness
consciousness,
paper.
okay, doctor. But
Yes.
with himself is not related.
Elevate herself, loss of consciousness, because patient's in front of you. Why do you think the patient loses consciousness? Patient is in front, is confused, is the case is mentioned and brought by the colleague. So witness is colleague, or maybe the husband. Of course. So this everything is clear here. You don't need these old details to ask very that did you have any jerky moment? It doesn't make sense, right? So the approach is quite a bit different. The most important thing, one is this, another resuscitation, and short question, and other important is the history of diabetes. This is very, very important. If you don't ask this history, you will lose your score. So since how long you're having diabetes? Okay. One more thing I want to tell you, the hypoglycemia is not only caused by the diabetes, but there are other causes too, like Addison crisis. For example, you come in the room and you ask the nurse to check vital and blood glucose level is low. Maybe the nurse would tell you by herself, oh, we have found the box, or this box with this patient. And when you open, maybe you find the drugs. Maybe hydrocortisone, these all things which suggestive of the Addison crisis, right? Then maybe you don't need to give the glucose, but in place of glucose, maybe you will give her hydrocortisone 100 mg, right? So this can be possible in different ways, okay? So hypoglycemia, not only because of the diabetes, can be with the Addison crisis. So you need to ask the question relevant to that. For example, if the diabetes, then you will go for the history of diabetes. For example, since how long you're having diabetes, what medication are you taking? When you ask the what medication are you taking, I'm sure nurse will give you a paper or a chart. It will mention the drugs. This patient is taking these drugs, okay? And then you will ask any new medication added recently. Maybe patient will say yes, as this one, insulin. So this was the case in real time, which is previous few diets came like that. So there was insulin. So you need to ask her, and then any unusual activity have you performed today? For example, you need to ask her, maybe it might be the cause of the low blood glucose, low sugar level. Another, how about meal? Because if the patient skip the meal, likely cause hyperglycemia with the drugs if patient is taking and not taking proper meal. Any ongoing illness other than diabetes, for example, patient has some other infection is ongoing, and that's triggers factor of the hyperglycemia or the further worsening. So this is why you need to ask, collect the history of diabetes. So these are very important. First, resuscitation. Second, diabetes, history of diabetes. So this all give you idea what exactly happened to the patient. Clear so far, guys?
Yeah.
Yes.
Okay. Is that make
Yes.
sense? Is that make sense what I said to you? So these
Yeah,
things.
the also patients coming hypoglycemia. Sorry.
Yeah, this if patient is
Hello?
with the yeah, I can hear you.
Okay, doc. No problem. Later.
Okay, so I'm so
Any young patients coming with hypoglycemia without a diabetes? Yeah.
it can be possible patient came up with the hypoglycemia, other causes, not exactly the diabetes, but should be the cause. Like we will come up in the next slide. What are the causes? Can be a distant crisis, can be another cause. Okay.
Okay.
Oh, okay, but resuscitation is the same, and the if it is the Edison crisis, then you have to ask the question relevant to Edison disease. Okay. Okay, so the important point, resuscitation. Here I didn't mention here above, so I need to write it down. Anyway, you should know about it. The patient came up and the patient is confused at the response to you. You need to ask the nurse to check vitals and check the glucose level. So it's not necessary patient should be in the resus. You just can be in observation room just to check out. Okay. After these all questions, you need to follow this all sequence and then go to the history of diabetes and then concern, okay, idea, concern, summarize, past medical history, all everything the same as usual. Okay, so this was about the confused patient. Let's come up with hypoglycemia and loss of consciousness. Okay. So now we are in the hypoglycemia and the patient is loss of consciousness. In this case, you can follow the approach which we did for fall and seizures the same way. What were you doing when this happened? Means you elaborate more and more. Here you can also ask about the vet or soil yourself because it does make sense, right? But in confused patient, you don't need to ask these all questions. Clear? I think it's clear to
Yes.
everyone, right? If the patient with hypoglycemia, loss of consciousness, you resuscitate the same way, and then you ask a history the same way is for the seizure and the fall, okay? But the one exception here is a difference in between fall and seizure that you need to resuscitate this patient to check. So how you will give the, for example, blood glucose level is less than 4 millimoles. So what you will do, what your step in this patient with loss of consciousness, guys?
Cannula, then patient have taken dextrose IV because
Yes,
he's unconscious.
yeah, that's
If
correct.
no line, we can give glucagon IM.
Yeah, the BNF guidelines say the first line is glucagon IM, okay? Then, because a patient doesn't have the IV line, till you get it, first you need to give him glucagon, then you will go for the glucose, etc. Clear? Okay, so resuscitate, and the patient's loss of consciousness follow the same approach. Is for the fall and other. But here, one more thing, you need to ask the diabetes history once patient is conscious. Okay, so let's come up with the cause, the seizures and the risk factor. Everything is clear? You can see it, right? You can see the topic as well at the top, no? Or it's not visible?
Topic is not visible. It's not visible.
Okay, now it's fine. Okay, so the seizure, the risk factor of seizure or premature birth, the complicated febrile seizure, genetic condition, etc. Head trauma, infection, meningitis, encephalitis, tumor, so many causes. You just need to look at it later. So what is the treatment for the, okay, let's come up the treatment management plan. And first we come up the investigation. Anyone can tell me what investigation will you order a patient present to you for seizure? There is no history of epilepsy
First
or
of
no
all,
any.
yes, sir.
Yes.
Blood glucose first.
Glucose. electrolytes.
Okay.
So I have to take patient to resuscitation room, then I will check, I will take ferret, the blood glucose for the patient, and also I will take the full blood count, urea and electrolyte, and VBG as well for the patient. And after that, if I found the glucose level is low, I have to just, because this also the main cause of sometimes for seizure.
Okay.
Also, we can do the ECG.
Okay. You are
After
forgetting.
that, we can.
You
We
guys
will
are
check the
forgetting.
clock.
Okay, you guys are forgetting very important investigation.
EBG or ABG patient, sorry.
EEG.
EEG.
ABGs.
EEG is very
AEG.
important for the
EEG.
patient with the seizure. So you need to tell that following investigation we will do. Okay, blood test, what else you say, the glucose level, etc., VBG or anything. But the important investigation is EEG. So how you will simplify to the patient in your own word?
I will tell him you have increased electricity in your brain, and we have to do one what's this one like tracing your electricity in your brain. So that one is called EEG.
Okay,
I
so
will tell the patient that
okay.
it seems that their electrical activity of your brain is increased, and I will conduct a test which is called EEG, in which I will connect some electrodes, some wires to your brain, and it will take the activity tracing of your brain, and that is called EEG.
Okay, that's great. The first is that EEG, you will not do it because you're EM physician, right? You will not do it. But you need to, you will refer this patient to the neurologist, sorry, neurologist, and then you will mention that while the neurologist special or the specialist will do a special test called EEG. In this test, what we do, we use a device to connect with your head or to attach with your scalp, and it will pick the electrical signal from your brain if they are unusual or the unusual electrical activity in your brain. If it's confirmed that, then you likely have epilepsy. Means you, whenever a patient come to you with the seizures, and if you found a seizure or showing like generalized tonic-clonic or these all like the eye rolled up, tongue beating, etc., so likely the epilepsy. But another can be a psychogenic non-epileptic the seizure. But for both, we need a neurological assessment, and neurologists will do that. And for both, we will do EEG, okay? Another thing you will say, the investigation after full blood count, what you can do, this MRI. You will mention that I will do MRI because the to rule out the mass in your brain which sometimes cause this seizure, number one. Another can be infection, okay? But the mass, you can say abnormal growth in your brain, okay? So these also cause in a stroke patient like elderly, maybe to check out the scar in your brain due to the stroke which you had it previously. So the MRI and EEG is very, very important. Any patient present to you in the EEG. EEG, you will talk about, say, the specialist will do this assessment, this investigation, but MRI and full blood count, etc., you will do. And the treatment, because patient the first seizure, right? And so that's why it's need a neurological assessment, okay? The neurologist to confirm that, because you cannot perform EEG. Another is the advice. What advice you will give to this patient, guys?
not to
Right.
drive for 6
Because
months.
you have to avoid the dangerous exercise and swimming, and also he have not
driving.
drive until just
Confirm.
to confirm his diagnosis. After that, we will inform Devla for 6
Yeah,
months not
DVLA.
driving.
That's good. Very good. Excellent. Yes, so he needs to avoid all kind of most dangerous activities. See, the swimming he should avoid. Okay, so these should be avoided, and also inform the DVLA. Okay, so clear so far about this? No any question? Okay, let's come up with the hypoglycemia. Anyway, the patient usually diabetes, and the most common cause is the drugs, the sulfonylureas, I think, and also can be insulin. Okay, so the other causes, as I said previously, can be exogenous drugs called alcohol, the beta blocker, pituitary insufficiency, liver failure, Addison disease, tumor, and also non-pancreatic insulin-secreting tumors. So these all can cause the hypoglycemia. Okay, if the patient is non-diabetes, so you need to consider alternative diagnosis. But for the purpose of exam, I don't think so. They will give you these. I still now know any station came up other than the diabetes. So, and usually relevant to the drugs. We will come up to those drugs. I also aid in the chart when we will practice in the station. I will show you how you will get this chart. I mean, exactly, she will give you, a nurse will give you the chart, and you will see the drugs. Okay, so next we have the syncope, and the first is reflex syncope, which is the vasovagal, first of all, due to posture, prolonged standing, less common after sitting, similar episode. Provoking factors can be fear, can be pain, can be blephobia, smell, etc. Progressive prodrome, such as pallor, sweating, and the brief myoclonus can be, etc. Okay. And the situational syncope is also in this reflex syncope. This is during or immediately following a specific trigger, for example, after micturition, straining, or pain. So patient will go for the short loss of transient loss of consciousness. Carotid sinus syncope, this one. So what is the treatment for the vasovagal episode, guys? Anyone?
Gradual desensitization.
What?
Only just the cause that is
First of
after the cause. What's the
posture of the
yeah, first of all, you will advise the patient to avoid triggers. Okay. Okay, like the
triggers,
if it is caused by due to fear, pain, or standing, you need to avoid that. Better to sit and avoid those places. If the patient has prodrome symptoms like pallor, sweating, for example, the patient is exposed to those triggers, and he has a symptoms like pallor, and he found it, and he suddenly recognized these symptoms, then he needs to lie down or sit down. Okay, this is advice you need to give him, the patient. Make sure the patient doesn't have recurring this syncope. If recurring syncope, then patient need a referral to the cardiologist or syncope services. Clear?
Yes.
Another thing in advisable age, you need to take increase the intake of fluids, at least 2 liters of water. Okay. Another, you need to advise him the physical counter pressure maneuver. physical counter pressure maneuver help the patient to increase, to better perform the cardiac stability, to increase it. For example, you'll ask him to knee crossing, for example, put one of knee on another leg, or leg crossing. It will contract the skeletal muscle and increase the flow towards the heart. So this can also help him. So you need to tell him, first of all, you need to avoid triggers. Next, if you had prodrome symptoms like you recognize pallor sweating, you need to lie down or sit down. Number 3, increase the fluid intake, like increase to drink 2 liters of water. Number 3 is physical counter pressure maneuver. This is according to guideline I'm telling, okay? What you have to do, you need to knee crossing or leg crossing. This will help you to avoid this episodes. Another is, this is according to European Society guideline, please note that, okay? Another, the review drugs, because drugs are also involved, so you need to review the drugs. For example, the SE inhibitor or the beta blocker can increase all symptoms, so you need to review the patient drugs. And then you can arrange follow-up with syncope in case of recurrent, or if he has a recurrent episode, then you need to refer. In both situational and also vasovagal. Okay, and also in the same in the orthostatic hypertension. Clear? Is this management plan clear for you guys? So in the ED, you will verbalize this everything to the patient. Okay.
Yes.
Okay. Regarding orthostatic, Dr. Same advice?
Yes, same. So for the same, because this is also the
Okay.
hypertension can be possible due to the drugs, or can be another. It's the same. Avoid triggers. Don't stay a long time. Okay. Better to sit if you have chance. Another important advice, because as you know that this is happening when you go from sitting to standing position, right? So what you have to say to the patient, when you are lie down, first you sit. Okay, follow these steps. First, from lie down position, first you sit and then stand. Okay, so it will help him to drop in the blood pressure, decrease in drop in blood pressure. Another important thing is that to head tilt, little bit raise at least 10 degree. Use the pillow to raise the head 10 degree when you are going to the bed. If patient is taking about the drugs, if patient is taking the SE inhibitor, then you change it into ARBS, angiotensin receptor blocker. This is according to NICE guideline. Or you change to the calcium channel blocker. Means review the drug chart. And about the water consumption, the same, like 1 to 3 liters per day. And one more important thing is about here is the salt. Should take the salt 10 grams per day. Okay. So this is about the authors. They both are almost similar. Few things are different. One is the salt consumption here, 10 grams. Another is about the res head to around 10 degree when go to the bed. Clear?
Yes.
Okay. Now we're coming up to dissonance and fall. This is very important because normally what people are doing, sorry, I still have some more things to do. I forget to do cardiac cause, yeah, arrhythmias, yeah. We are here, arrhythmias. So I have found 2 stations, which is the very common. The Brugada syndrome can be common in this case if the cardiovascular syncope, or can be the heart block. Anyway, so let's come up first with the long QT syndrome. It's the most common cause due to drugs. So let's come up with the Brugada syndrome. So guys, if you found the patient is feature suggestive or Brugada syndrome, and you got the ECG and you found it. So what treatment you will give to this patient?
ICD.
Okay. Another guy? Another?
First, you have to stop the offending medication and treat the triggering factors.
What could be the
Refer to cardiologist.
Triggering factor could be the medication or any electrolyte disturbance, or could be congenital. Then accordingly, then the ICD, question of ICD to protect from life-threatening arrhythmias.
Okay, that's great. So the European Society of Cardiology, I think the British Society, last time I checked it. So the British Society of Cardiology states the patient, you ask him to treat the triggers or the factors which are increasing. You know that this is because due to heartbeat very fast, right? So what situation can make it faster? Like patient in fever situation, right? Temperature, right?
Arrhythmias.
Dehydration, right? These can make it worse. So in this case, patient can be collapsed suddenly. So first of all, your advice to this patient before you come to ICD, okay? You will say to patient that whenever you have temperature, advice, you need to use paracetamol to bring down your temperature. Dehydration, avoid dehydration, take frequently use of the fluid. Okay, keep yourself hydrated. Okay. Another case, in case your heartbeat is very fast, okay, you come up to that, we will insert a device, a small device, okay, small device near your collarbone. It will help you in case it's very fast heartbeat. It will give a shock and to normalize this. Okay, you will verbalize that. But first of all, what you have to do for this, you will of course refer to cardiologist. But what you have to say, you need to tell the management plan. Not every patient with Brugada need to go to the cardiologist because Brugada doesn't have no proper treatments till now. Clear? So you need to tell him everything. In severe cases, refer to cardiologist. Anyway, even not severe, but you need to arrange follow-up with appointment with the cardiologist. Okay. Any question here? So far clear here, right?
Yes.
Yeah.
So for
As-
instrumentational syncope, anything that we can advise or anything not to be done? If a patient is having a BPH,
I couldn't get you about you're talking about Brugada
okay,
syndrome or something another.
syncope. The trigger factor could be instrumentation, let's say bladder catheterization for a patient with prostatic hyperplasia, self-catheterization.
Trigger factors, I haven't found anything like that, but it can be. But anyway, any trigger factor he needs to avoid. For that, maybe you need to refer to the syncope service. What they usually do, because usually what they do, they review the medication also. But as I said, if it's it's not a recurrent syncope, then you can discharge with the safety net. Okay, the management plan I told you, this just need to follow. Okay, this is according to guideline. You can discharge this patient from ED, but if a patient is recurrent, so this needs assessment, broadly multifactorial. So for that, you need to refer to the syncope service or relevant to cardiology. So you need to refer to cardiologist for that. Clear? So usually the cause most common is cardiologist, the heart, CVS, I mean cardiovascular system. Clear?
Yes,
Yes, sir.
yes.
Okay, so the next is dizziness or fall. So this is very important about the fall. So could you please tell me what patient age would be if it's come to you ED with the fall complaint? What do you think?
Elderly patients.
Old age.
More than
Yeah.
60.
Yes, around 60, more than 60 means like this kind of patient will come up to you elderly, and there are many factors which are the due to that patient have this problem. Can be the musculoskeletal dysfunction, foot problem, cognitive or neurological impairment like Alzheimer, cardiovascular infection, the environment hazards, or the polypharmacy like the antipsychotic drugs or antidepressant, and many other things. So designate the patient, if it's vertigo, maybe go different ways. But if it can fall be due to this multifactorial. So what you will do, guys? A patient come up to you, what you will do in the ED? What's your job in the ED patient? 65-year-old, and he said, I fell down. Okay.
Make sure patient's vitals are stable.
Okay, you did it. This is very, very normal, important things which I want to know. Yeah.
I have
And
to I have to check with the social service for the patient if you have recurrent history of fall.
Check
I have to check
BP.
also the activities of the patient at home, what he's doing, what he's using for his housing, stairs or lift, if there is any mechanical cause, for example.
you guys are forgetting very, very important
I will
assessment
assess.
tool.
We'll take the BP while standing and sitting and on the both limbs.
Positional, is it a positional dizziness or non-positional?
I will assess the patient. I will assess the patient first. I will ask him if he could go or walk. I will ask him to walk to see his gait first. After that, I will do proper examination, full examination. I will advise if he is taking any medication, and I will ask him about housing condition. What environment he is, what his work. Are there any companies with him, any family relatives with him in the house?
Okay, okay, whatever. So I'm coming to very, very important two things. What is the
pain and injuries?
Anemia and sepsis.
okay? No problem. I'm coming
BP
to
while
this.
standing.
I'm coming to this point, please. Wait, this one girl, she said about, I don't know what's her name. She told the patient I would check the gait, etc. Okay, good. But the special tool's name is time up and go test. You will do time up and go test, which we call in the short word TUG. Okay. This we need to do in the ED. Another test is called the turn 180 degree. So these two tests we use for any patient come up with the fall, okay? If you don't go with this test, so just to refer this patient to fall clinic, it doesn't make sense, okay? So time up in the go test is very important. You will ask the patient to get up from a chair without using arm, okay? Walking 3 meters, turning around and returning to the chair and sitting down. In this test, you need to verbalize. I will ask you to go this way, okay? Get it from from chair sitting position. Then you will, without using your arm, walking 3 meters and turning around, then back to. You can check this test on if you want, okay? Another test is this test is important scoring, so you can just verbalize. We do a special test, and I will see if it's abnormal. Okay, I will refer you to the fall clinic. Okay, if it is the first fall, If it's a recurrent fall, we will come up to the guideline when we need to refer this patient to the fall clinic. Okay, I ate the screenshot. We will come up to that. Okay, see, another test is the turn 180 degree. In this the test, what we do, we put the two chairs in between. We ask the patient to turn opposite, follow these steps. This is first patient will look at you, then move forward and turn around, then turn to another side, which we call 180 degree. That's why. So we need to count the steps here. How many steps does patient takes to turn to the opposite side? Okay. So the scoring system, which is different, but I have which we use the 12 to 15 second or more, depend on so different scoring system. This indicates a high risk of fall in this older patient. Okay, so different scoring system, but you don't need to mention everything. You just need to verbalize this following test you will do, and what you will do in this test, blah, blah, you will do. Okay, so this is very important. Clear, guys?
Yeah.
Yes, sir.
Can you
Yes.
again just tell us the turn test
Okay, write down in your paper
in
and
the
check
two
it.
chairs?
Yeah, listen to me. Write down on the paper and check it by yourself on. Okay, I just tell you the name of the test. Time up and go test. Okay, time up
Okay.
and go test, and turn to 180 degree. This is the patient elderly, which were the complaint with the fall. They come up to ED. We do this test. Okay. You need to verbalize that we will do two special tests, or the called one is time up and go. If it's come abnormal, I will do blah, blah. I will refer you to the fall clinic. What the fall clinic will do, let's come up to the fall clinic. Fall clinic, you need to tell them the fall clinic will, first of all, give you training. It's training, okay? Training about your activities, means how to walk very well, how to increase the function of the muscles or etc. And also they will review your drugs. Okay, maybe they will change your drugs which are causing this problem, like if patient is antipsychotic or depression. This is done by the fall clinic. Okay. In other things, they will train you about how to avoid the home hazards. For example, patient exposed to the fire, patient exposed to any paint or any dangerous thing at home, the warm water. So these things you need to verbalize to patient if you have a time. Okay, so these are very important. Don't need to just quickly say, I will refer you to the fall clinic without your assessment. You need to finish your assessment like tug and also turn 180 degree, because these are very simple tests which you need to do. If you want to get good score, verbalize would be better. Another, we have this one.
So how many seconds are you? So how many seconds would be abnormal? More than turn 180 degrees?
12 to 15, according to the nice size, would be high risk of fall in this older patient. But different tools can be less than 20, can be less than 30. You can check the chart, okay? There is a special chart, we use it, so you need to check it out. Okay, so another is the important, this slide I added a screenshot from Nice Guideline, so you can see it. You can choose the name from here also. Offer a multifactorial fall risk assessment, appropriate skilled and experienced clinician to all people aged 65 or over who had 2 or more fall in the last 12 months. Okay. So this you need usually is done by the fall specialist. You need to refer this patient who had 2 or more fall in the last 12 months, present medical attention following a fall. Okay. Cannot perform poorly on the time up or go test. So when you do test, if you find he's not performing very well, since the score is low, you need to refer to the fall clinic. Clear? You can save
Yes.
this screenshot with yourself, or you can write down. So remember, the fall patient, do not jump quickly or do not think quickly. Okay, a patient came up and you want to refer, okay, refer, etc. No, this is not a good thing. You will lose your score because they want to test you. Okay, so next slide, we are having the presentation of vertigo. We already did it. We did in Adipara. Let's leave it so we don't go for that. Okay, guys, so this we have done already for all the notes, and we are going to have soon stations which we need to practice. Do you want to have a break, guys?
So one more question regarding faintishness.
About what?
Faintishness. The difference between dizziness and faintishness.
The dizziness and fainting almost the same actually, but the problem is dizziness, you need to elaborate more. For example, what could be the cause? Patient maybe say maybe it's due to vertigo or maybe another reason, so you need to elaborate. Fainting is just like a syncope. Both can be possible together. Clear? But the syncope is...
Can I ask a question? Sir,
yes.
What would be the treatment for syncope due to heart block?
Yeah, so what is the treatment if the patient, the risk factor we learn in already in the research council. So what is the first line, guys? The Mobis type 2 and the third degree, what we give the first line treatment. Do you remember? In research council.
Yeah, those are pacemaker.
Transcutaneous pacing or
No,
permanent pacing?
You are going suddenly to trans. Before that, we have a first line treatment.
Atropine. We are doing
Atropine. Yes.
Atropine. Yes.
Atropine. Yes, that's correct. Atropine. You need to go for atropine first. Then you go for transcutaneous pacing or transvenous, etc. And before that, even we go for other drugs called isoprenoline, etc. Clear? Clear, guys?
Just one question, Dr. B.
Yes.
Regarding the state of for elderly, how this patient will come? Like just patient fall and...
Okay, so I want to give you a little overview about the station. Okay, this is about very visible that what could be. Okay, now you will have drug charts like this. I will give you. Let's come up to the fall. Okay, let's look at this station. For example, patient fall and he is complaining about left shoulder pain. So you don't need to, you need to focus on the fall event approach. Don't need to follow Socrates, but when you ask this patient, did you injure yourself? Patient say, yes, on my shoulder. Are you in a pain or are you comfortable? Just need to ask, how would you rate your pain? Maybe patient say 5 to 10, and you just need to take more question from that question. Okay, close question from that question. For, are you injured yourself? Yes. Where? Shoulder. So in this case, you need to give both management plan. First, you will treat his shoulder, you will do x-ray, etc., painkiller, then you will come up the fall. For fall, you will do assessment. Means you need to do two things here. Clear? Fall, I don't think so. They will give you, oh, patient came up fall, take the history and explain. No. Maybe they will add more thing in the fall. For example, patient has fall and he has a shoulder pain now. Maybe they will say patient has a hip pain. Maybe patient is a foot pain or etc. So you need to see that you need to manage both. You will go for assessment for the fall. First, you manage the shoulder pain, do the x-ray. You will say if the x-ray show the fracture or will refer you to the orthopedic. You also need to mention. And for the assessment of fall, you need to say, I will do assessment. I will do timed up again go test. If it's abnormal, I will also refer you to the fall clinic, etc. Clear?
Yeah.
Sir, one more question.
Yes.
Sir, we mostly ask the patient, are you in pain? May I offer you some analgesia? Sir, what kind of analgesia should we offer if patient is in severe pain or mild pain?
Yeah, give the paracetamol. You don't, you know, this is Socrates usually, but you can ask here if patient, when you ask patient, are you comfortable or are you in pain? Patient say no. So you say, do you want me to give you a painkiller, just verbalize? Or do you want me give you paracetamol? Or are you any allergic? Maybe you can elaborate, but you don't have time, so you need to skip. Just say, do you want me to give you a painkiller? No problem which else
Okay.
you give. They don't want to test you about that. They know it because you already passed intermediate, so you already gone with these signs. Clear? Okay, so
Okay,
this
thank
is this station I made a little bit complicated for you guys because I want you should think different ways, not only the one way. Station can come up with different ways. This you will follow the full approach, but the things are different here. Means you will also manage the pain. Clear? Another station we have the collapse. You see, the idea can give you from 66-year-old. That means the vasovagal can be orthostic, can be arrhythmias. From this, you can guess, okay? If it is quickly goes to the loss of consciousness. Another is the station is young. You see, this girl is very young. An episode of collapse. She's worried. So it can be seizure. And it can be the heart problem, can be brugada, can be hypertrophic, can be dilated myocardium, the ventricular cardiomyopathy, etc. So this can give you idea. Another is 33. This is also very young. Okay, so we have very few station. I forget to add one more station, which is very important, without pain. So I will make it without pain one station for you. It's about the collapse. Okay, so let's come up after 5 minutes. Okay, guys? Clear? Do you have any questions?
Can you make it 7
Okay,
minutes?
sir.
Yeah.
What do you say, please? Excuse me? What's your question?
Yeah, 7 minutes. Here.
Yeah, here will be inside we will practice with the 8-minute total, 1 minute reading if you want to read. If you don't want, you just see over and then we come up to 7 minutes. Yeah, practice would be 7 minutes. But in the exam, you will have total 9 minutes, 1 minute outside of the station, 8 minutes inside of the station. Means a lot of time. Believe me, you will have a lot of time. Okay, so let's have a break 5 minutes. We will come back with 5 minutes. Okay, Dr. Mrcem. Can you hear me, guys? Does it sound clear now? Actually, I'm using the...
Yes, sir.
Actually,
Can I
I'm
start
using...
again?
Yeah, you can start right now. Is I'm using the data, so it's a little bit a problem. Okay, anyway. Yeah, let's continue.
Okay. Okay. Hello, I'm Dr. Mrcem. I'm the ED registrar. Can I please confirm the name and age?
Yeah.
The patient is confused. And blood sugar of the patient. Can the nurse please give me the details?
Yeah, the blood sugar level is 3 millimole.
Okay, can you please give oral dextrose saline to the patient?
Okay,
If there is
given.
any juice, please give juice. Given.
Okay.
Can you please recheck the BSI?
Yes, we have juice. We give him. Give her.
Okay. Okay.
Yeah.
Okay. Hello, I'm Dr. Mrcem. I'm the ED registrar. Can I please confirm your name and age?
I'm George. I'm 55.
Okay. Nice to meet you. Nice to meet you. Where are you right now, George?
I'm in the hospital.
Okay. And do you know who am I?
Yeah, doctor.
All right. So you've been brought by a colleague with your husband with the low blood glucose level, and we just gave you some juice. So now your blood sugar level is hopefully normal. How are you feeling now? Are you better? Are you
I'm
comfortable?
okay. I'm okay.
Okay, okay. Now I would like to know something about your condition, about the low sugar level that you just had. Do you understand what I'm telling you?
Yeah, I got it.
And are you okay with me taking this history, taking this information from you?
Okay.
All right. Do you remember what exactly happened?
Yeah, I was doing some work at home in the kitchen, and I don't know. I don't know what happened then.
And what were you doing in the kitchen? You were cooking or what?
Yeah, I was just cleaning.
Okay. And are there any injuries that you have sustained? Have you injured yourself?
No,
Okay. Have you ever had the similar episode before?
no,
No. Okay. Have you noticed any other changes in your any bowel habit changes in your bowel habits?
no,
Okay. Have there been any recent changes in your urine, any blood in urine or any discharge?
no,
Yeah, have you had any temperature or any fever recently? Or any infection?
no,
Have you been experiencing any weakness or numbness of the body?
no,
Okay, has there been any rash
no,
in anybody? Okay, have you experienced any chest pain or have you felt any your heart racing or dizziness in past 2 days or
no,
during this episode? Okay, have you experienced cough or any respiratory tract infection recently?
no,
Okay, do you have any headache or any vision problems?
no.
So I would like to know about this diabetes. I think you have diabetes. So from how long do you have this problem?
Over 5 years.
5 years. All right. And what medicines are you taking for that?
Yeah, the nurse gave you this one. This one.
Which med? Oh. Glycoside, and metformin. All right. And have any new medicines been recently added to routine medication?
Yesterday I went to the GP and he gave me this medication you see in the top.
All these three have been added newly to your regime, right?
No, this new one. The first I was very good. I was fine. I don't know today. I'm here, and yesterday JP gave me this medication at the top.
Okay. And you haven't taken this morning and evening? Or just in the morning?
Morning and evening, twice.
Okay. And is there any unusual or different activity that you perform today, specifically?
No.
Okay, when did you last eat?
When was where? What
When did you last eat? What was your last meal? What was your last meal?
Last meal around 5 hours ago.
5 hours ago. And what was it?
I had a breakfast with a chunk of bread, a slice of bread, and also the egg, and the boiled egg.
Okay. All right. Do you have any other medical illnesses along with diabetes?
No.
Okay. So what do you think is the cause of the blood sugar? Do you have any idea of what happened to you today and why did it happen?
I think maybe it's just a new medication. I think I found that since yesterday's a problem. Yeah.
Okay. And are you worried about it? Is there any specific thing you're worried about?
Yeah, it's first time up and I'm really nervous. I don't know what's going on. You just told me that
Okay,
you give me, yeah.
Don't worry. Inshallah, things will get better. So what were you hoping that I'll be able to do for you? Any specific expectations from my side?
I want to see this medication. It need to be changed or what?
Okay. Now let me summarize what you told me. If I say anything wrong, please correct me. So just you came here and your blood sugar was low. We gave you some dextrose, some sugary drink, and it got better. And you are diabetic from past 5 years. And recently, another medicine, insulin, has been added to your regime yesterday by the GP. And it is after that medication that you felt this condition for the first time. Am I right?
Yeah, that's correct.
Okay. Okay, all right. And there is no other medical condition that you have.
No.
And other than these three medicines, you're not taking any medication?
No, any other medication.
Okay. Are you allergic to any medicines or drugs that you know of?
No.
Okay. And any medical problem running in your family?
No.
Okay. Can I please know where do you live and what do you do for your living?
I am a housewife.
Okay. And I'm sorry for the next question, but do you smoke or drink alcohol?
No.
Okay. And are you taking any recreational drugs?
No.
Okay. And have you had a travel abroad recently?
No.
Okay. All right. So it appears to me that this episode that you just had, it is hypoglycemic episode. It means that your blood sugar got very low. First of all, let me tell you that there can be multiple reasons for this. As you are already diabetic, so the reason that appears to be is that another medicine, insulin, has been added, and often when insulin is first added to a regime, patient may experience these things, and in this case, your insulin levels may need to be changed. You also need to be very careful that you have to take your meals on time. You have to take insulin, and right after taking insulin, you have to take your meal. You don't have to quit your meal. There can be other reasons that can cause hypoglycemia. This episode of low blood glucose, which can be due to some other drugs, which you are luckily not taking, but it can also be problem with liver or a problem in the gland called pituitary gland, or some disease, another disease which is called Addison's disease. And there is also a disease called insulinoma, which can cause this condition. But
Okay.
in your case, I will refer you to your GP, and so your simple insulin regimen needs to be changed. It just needs to be adjusted, and you need to be very careful about your meals, and you will be good to go.
Okay. Thank you. Okay.
Thank you.
Time was very long. Anyway, in the exam, you will have enough time, and you need to little bit faster. Okay. So guys, what do you think? What is the cause of this condition? Why is the glucose level is low?
New drug. Insulin was added newly.
Yeah, insulin is the new drug, and this is the cause of this one. And you need to be very, you need to be clear crystal. Don't need to go for insulinoma, don't need to go for Addison disease, etc. You don't need. You just say it's likely because due to drug. And so what you need to admit this patient for 24 hours to 24 hours till it's monitoring of his sugar level. And then you will discharge this patient to the follow-up with JP. Clear? Dr. Mrcem?
Yes, sir.
Yeah, you need to admit this patient. Don't need to refer this patient. No need any referral. This patient needs admission, okay? Then you say, I will monitor your sugar level till 24 hours. If I found that it's going better, you're okay, I will discharge you okay, towards your GP, or I will write a letter to your GP, or I will arrange a follow-up with your GP. Okay, but the cause, you need to be clear based on your information. The most likely problem due to your new drug called insulin, and also you skip the meal. So these both can be likely cause, and is further the trigger of your hypoglycemia. Means you can say the low blood sugar. So you need to say like that and make it very short and simple and straightforward to the point. Don't need to be divert to move to insulinoma. Don't need to move to the Addison disease, etc. These are not necessary because this cause is very clear. Okay. Okay, another thing is the approach. Yeah, you did well, but you're very slow. You need to be faster. Okay, and the repetition of question is not good. Try to one time ask and move faster. Okay, so the next station we are going to have it. So guys, who wants to practice? One more thing I want to advise you, Dr. Mrcem, to everyone, please let the patient talk, okay? And give the information in chunk, means a small pieces from, not like everything. Any bowel changes or nausea, vomiting all together. Don't use that. Make it short and simple. Okay, any bowel changes, any problem in urine recently? Do you found any changes in your urine like this? Have you noticed, better to say, have you noticed any changes in your urine? Have you noticed blah, blah? So try to use the good sentence and the standard one, okay? Okay, so
Dr. B, I have one question about the new drug. Do we advise the patient to stop the new drug, or do we lower the dose? What would be verbalized to the patient about the new drug?
And you need to do it, require maybe the dose adjustment for the new drug. However, I will refer you to the GP. For now, I stopped this drug, but for temporary, you have to do, but you need to write the letter to the GP, and GP will decide what have to do. For what, for you need to stabilize this patient in the ED. This was your job, and monitoring 24 hours this the blood sugar level is stable. Any patient with hypoglycemia due to the drugs or anything, you need to admit this patient. Remember that. Okay.
Okay, thank you so much.
Okay, so who wants to practice, guys? Next one.
Me.
Okay, that's great. Okay.
Okay. Hello, I am Dr. Medina. I am AD registrar. May I confirm your name and age, please?
Yeah, I am Jake. I am 30.
Yeah, nice to meet you.
I am 65, yeah.
Nice to meet you, Jake. How can I help you today?
Yeah, I fall down and on the floor. Yeah,
Sorry
today
for
in
hearing that.
Today morning, yeah.
Sorry, I'm hearing that. Are you comfortable now, or you have any pain?
Yeah, the nurse gave me the painkiller at the bag when I just came in.
Okay, very good. So let's some that from you. Is it okay with you?
Okay.
Okay. Can you tell me more about what happened to you? How did you fall?
Yeah, today morning, I just wake up to go to the toilet, and I get up and I just walk. I fall down, and then I try to wake up, but I couldn't. And I just crawl and to get my phone and I call ambulance.
Okay, sorry, I'm hearing that. So when you are got up from your bed, when you are standing and walking few steps, then you fell down. I'm correct?
Yeah, and also I injured my shoulder. Painless, but yeah, that's correct.
Okay. How the pain it is severe or mild pain?
No, it's okay now. Fine. After painkiller.
Okay. Okay. Before you are falling down, do you feel any chest pain?
No,
Okay. So any dizziness?
no,
Okay. Did you feel any heart racing?
no, no.
Okay. So any headache you feel?
Uh,
Okay.
no, any headache. Yeah.
Okay. So are you remembering what happened, or do you think you lose your consciousness?
Yeah, I think so. I lost my consciousness for a couple of minutes.
Okay. Okay. So no witness around you, nobody with you.
Yeah, I live alone, nobody. Yeah, my daughter sometime
Oh,
came.
okay. Okay. So do you notice any tongue bite?
No,
Okay. So any vision problem after that?
no.
Okay. So do you remembering what happened exactly after you recover?
I don't know what happened before fall there. Yeah, I just
Mhm.
remember I want to go toilet and then fall. I don't remember anything since then.
Okay. So before this one, do you have any high temperature?
No.
Okay. So any vomiting, any diarrhea?
Oh, I just feel nausea.
Okay. Okay. So what do you think the cause of your fall, Mr. Rick?
I have no idea. No clue.
Okay. Is this happened before for you? This
No,
problem? Do you fall before?
no.
Okay. So do you have any medical disease? Okay. Any family disease running?
The medical disease, yes. I'm a stroke. I had a stroke before, and I had a stroke before. Yeah,
Mm-hmm. Okay, you had a stroke. Okay. So no
and
diabetes, no
also,
hypertension.
I also have depression. Yeah.
Okay. Are you taking any medication
Yeah, I'm taking medication for a
for
stroke and for antidepressant for my depression.
antidepressant? Okay. For a long time you are taking or recently?
I'm taking from last 1 week. Antidepressant, a stroke from last 3 months.
Okay. So where do you live and with whom?
I live alone here, in my home.
Okay. So what do you do for living?
No, I'm retired.
Okay. Just I want to ask you some personal questions. Is it okay?
Okay.
Are you taking alcohol?
No,
Okay. Do you smoke?
no,
Okay. Or you are not taking any other illicit drug?
no.
Okay. So let me just to sum up for you, Mr. Jake. If I forget anything, please let me know. Today morning, when you are wake up from your sleeping, just you stand up, then walking few steps, then you fall down. After that, you loss of consciousness, maybe 2 minutes, and you have sustained injury. You have a shoulder pain after that, and you feel also a small tongue bite. Okay, you
No,
are known case. Yeah. Okay. So my plan for you, Mr. Jake.
no tongue bite.
Yes.
No tongue bitten, please.
Tongue bite. Okay, sorry. Okay, sorry. Okay, so and you have past history of a stroke, and also your known case of depression, and you are on medication. Okay. So Mr. Jake, my plan for you, I think your problem, it could be you get some something called orthostatic hypotension, your blood pressure when you are waking up and you're standing suddenly, maybe it drop. Then I need just to recheck for you the blood pressure when you are sitting and you are standing. Then I will see if there is 20 millimeter mercury different. This it may be the cause of your fall. Other cause also it could be also your medication. Maybe also it can cause the dropping of blood pressure, and also it can cause for you this kind of fall. So I will just do some test for you. I want to just to assess as a fall for you. I will do two tests according to my guidelines. One test it called time up test, and other one is no time and go test, and other one it is turn test. Okay, I will ask you just to get up from the chair and go for 3 meters and come back to me. Okay, then I will assess your risk of fall in this walking. Another one in two chair. Okay, I will just let you to turn opposite this one, and I will count how many steps you did, and that one also it will help us to check if you have risk of fall or no. Other thing, I will follow you to clinic. It's called fall clinic. Those ones they will help you regarding. They will review your drug, and also they will give you some advice regarding to avoid the fall. Okay, and also my advice when you are get up from your bed, you have to stand, sit. You have to sit then standing. Okay, and also you can head tilt your head 10 degree by below. Okay, and take too much water. And also I will advise you to take salt daily around 10 grams per day. Okay, are you understanding my plan, Mr. J?
Okay, thank you.
Okay, do you have any questions?
No, thank you.
Okay, thank you.
Dr. Medina, you mix up two different things together.
Yeah.
So, guys, what do you think, and what could be the management plan for that? Anyone?
I think we have to manage the shoulder injury because the patient has a shoulder injury, so X-ray need to be done for that,
Yes.
and patient have to be referred to the orthopedic, and simultaneously you have to give the fall plan also. But first, priority is to manage the shoulder injury.
Yes, shoulder injury, you will do X-ray. If it's come abnormal, you will refer to the orthopedic. Okay, that's good. But the thing I'm talking about fall, I told you, and we discussed previously, is multifactorial assessment. Okay. Okay, the cause of fall is multiple. First, the patient has a stroke. Okay, so it can be cause the scarring in the head, or can be another cause like wasting of muscle, can be musculoskeletal cause, can be another different causes, could be, right? So, but you need to do two assessment for this patient. One is which one test I told you guys? Time up and go test. and turn 180 degrees. This patient is not about the vasovagal syncope or anything. This is not relevant to here, okay? Clear? This patient is about the fall and injury. You need to go for the assessment like time up. You can say this, the problem which you are based on your information, your fall, there can be the many problem. Therefore, I need to, but regarding your shoulder pain, I need to do x-ray, and then you come up the fall, okay? First, you clear one thing and then come up to the fall. The fall regarding your fall, this can be multiple problems. So I need to do a special test called time up and go test and turn 180 degree. Okay, and also I need to, as you said, you had a stroke, so I also need to do MRI, okay, or the CT scan. Then you say if the test come abnormal, if I suspect it, then I will refer you to the fall clinic, and fall clinic will give you following treatment. They will give you how to strengthen your muscles, the exercise, and now they review their drugs as you are taking antidepressant, etc. They will also the guide you how to avoid the home hazards, these all things, right? Excuse me, yes?
Okay.
Okay, so clear what I said? So this patient...
I have a question. I have a question, if you don't mind.
Yes.
This is an old age patient and a history of fall. So should we go for the ATLS protocol in this case? According to ABCD, as the patient have got loss of consciousness as well along with the fall.
Patient has loss of consciousness in the morning, not now. Okay.
For 2 minutes.
Yeah, in the morning, not now. Patient is in your department right now in front of you, communicating with you. So this is not the ATLS. ATLS, you will see, we will come up, it's different. In here, this is history taking, but the approach is different. How you fall, when did you fall, and what were you doing? These all come up in this fall. So we already discussed in just now, a few minutes ago. So you need to follow this approach, okay? So Miss Dr. Medina, you did well, but you mix up two things. And the cardiovascular, you bring up syncope in here, which is not right, okay? And even though the orthostatic or hypertension, you need to, it's the first time, so you just give advice and discharge him, okay? No need any referral. Clear?
Okay.
Okay, who wants who wants to practice any other candidate? Anyone?
Yes, doctor.
Okay, that's great. This is station for you.
Yes, could you hear me?
Yeah. Yes. You can start. You can start.
Yes, could you hear me? Yes.
Yes.
Hello, this is me, Dr. May, AD registrar. May I know your name and age, please?
Yeah, I'm Wendy, 68-year-old.
Nice to meet you. How old are you?
Yeah, I'm 68.
Okay. May I know what brought you to AD today?
Doctor, last evening, I was sitting outside in a park and I just found I wake up. and I want to walk, and I don't know what's wrong. It's just a blackout in front of me, and I fell down. And yeah.
Okay. So sorry to hear that. Did you hurt anything? Did you fall anything or hurt anything in any part of your body?
No, no.
It's okay. Any witness around you when this happened?
Yeah, one of my friends.
Okay. And could you tell me that what happened before this?
Yeah, it's
Did you feel anything? Mhm.
nothing. I just wake up and suddenly black out, and I don't know if I fall down.
Okay. Anything, I mean, anything before this walking, you was walking for a long time or just a few minutes or what?
Yeah, I mean, how long I fall down, right?
Yes, exactly.
Yeah, maybe 2 minutes.
2 minutes. And the weather was sunny or it's okay with you?
Okay.
Okay. Did you lost any? You lost your consciousness?
Yes, yes, I lost it for 2 minutes around. My friend told me 2 minutes.
So your friend tell you. Okay. And did you wet yourself?
No,
Okay. Any heart racing before this syncope happened?
no,
Okay. Any headache?
I know headache, but blackout, yeah.
Okay. Any vision disturbance?
Yeah,
There is vision disturbance. Okay. Chest pain, what there or no?
no,
Okay. Then did you experience on any jerk movement?
no,
Okay. Do you have any diabetes?
no,
Hypertension?
no. The
Any cardiac
hypertension,
diseases?
yeah, I do have the high blood pressure, for which I take medication.
Okay. You are taking medication, and you are fixed with your medication, right? You are taking it regularly, I mean.
Yeah,
Okay. Any heart diseases?
no,
Okay. So are you working?
you know, I stay at home.
Okay. Sorry for this, but are you smoke?
No,
Okay. Taking any kind of alcohol?
no,
Okay. So as information you gave it to me, it seems like just syncope or what is it? What we call like it's like a vasovagal syncope. So it happened during when the patient is with the somebody was standing for a long time or walking for a long time. You said like 2 minutes you are walking, right?
no, walking. Yeah, I was sitting. Yeah, no walking. I mean, I lost consciousness
No
for
walking.
2 minutes. Yeah.
Okay. Okay. Just to be in the same page, you was sitting and suddenly stand up,
Mm-hmm.
or you
Yeah.
are working. You are
Yeah,
walking.
Yes, well, I was sitting. When I standing up, I fell down. That's correct.
Okay, so based on what you mentioned, it seems like it's vasovagal syncope. It happened when when somebody was sitting for a long time and then suddenly stand up. So the whole blood pool in his leg, and he lost his consciousness for just a temporary time. Okay. I will do for you some lab tests. Okay, and we will do like ECG because already you are hypertensive and you are taking medication, so we'll do some ECG and lab test. And I want just to give you an advice when you are standing from sitting position, just to do it gradually. It's not like sudden stand. Okay, and also drink plenty of water. Okay, and keep yourself always hydrated. Okay, and avoid like sitting or be exposed to sunlight for long time. Okay.
Okay.
Do you have any idea about what is going on with you?
Yeah, I think I have no clue about it. Yeah, but I think I need to hydrate myself. Yeah.
Okay, very good. And do you have any concern about it?
No.
It's okay. Do you expect anything from my side?
You already told me. I need to drink a lot of water and yeah, and avoid
Very
sun.
good. Okay, very good. I just remembered to ask you one question. This happened before, or is this the first time?
First time.
First time. Okay. So and accordingly, it's the first time. So no need at this point to do to worry. But if this recurrent again, we will at that time we will see if we could refer you to like syncope doctor to do like further investigation and workup. Okay.
Okay, thank you very much. Okay, so doctor, I want to correct you a few things. You didn't go with the systemic review. Number one. Number two, you forget ICE. After systemic review, you need to go for ICE. Okay, and then summarize. Then you come up to the management plan, but you go management plan, then ICE, then this whole thing. Okay, anyway, you need to be very careful. The event approach, then systemic review, okay, then ICE, then let's summarize, or you can ICE do after the approach. It's up to you. So you need to follow the approach. First, you need to correct your approach. Number two, guys, what is the diagnosis in this case? What's the cause of this patient?
Maybe orthostatic hypotension.
And the patient is having orthostatic hypotension, okay? And likely caused due to the drugs which he's or she's taking. Okay, so just need to advise and discharge this patient.
Okay.
Clear?
Yep.
Okay, anyone, guys, please focus on your approach. Many of you guys still skipping many of things because they don't. The approach is very easy to get it because you just need to memorize approach. You even don't need to be very focused. The concentration should be on the management plan. The diagnosis is very important. Okay, so who wants to practice next one, guys?
Yes.
Okay. This is station. Dot.
Hello, I am Dr. Mohammed, one of emergency physician here. Could you confirm your name and age, please?
Yes, I am Vivian. I'm 38.
Nice to meet you. How can I help you today?
Yes, doctor. I don't know what's wrong with me. Yeah, I feel not good today. I feel like I'm worried. I just how to say I fell down, and my friend told me something goes very strange with me.
Sorry to hear that. You feel falling today, and you told me something strange. Could you tell me more about this?
Yeah. Today I went to shopping with my one of friend, and when I just finished, I came outside, and I don't know what's wrong. My friend told me that, yeah, I fell down. I was on the floor. Something strange. Yeah, she said like that.
We are here to help you. So before that, before what happened, do you feel any fever?
No.
Any shaking in your hands?
Yeah, my friend said, yeah, I was shaking. My body was strange feeling, like she said it was shaking, something like that. Yeah.
Yeah. Did you feel any rolling up of your eyes?
Yeah. My friend told me it was, yeah.
Yeah, okay. Any weakness in any part in your body?
Now or before?
Any chest pain?
No.
Any heart racing?
No.
So during what happened, did you wet yourself?
No.
Did you soil yourself?
Maybe a little bit, yeah.
Okay. Did you bite your tongue?
I feel a little bit pain in my tongue. It's on left side, so maybe.
Yes, okay. After what happened and you regain your conscious, did you recall all what happened?
I don't know, doctor, what happens. This all told me my friend.
Okay. So any injuries in your body?
No, no.
Do you have any past medical history like epilepsy or any mental illness?
No, doctor. I'm very fit and well all the time. I don't have any problem.
Good.
Just this
Good.
happened yesterday.
Good. And do you receive any regular medication?
No.
Do you have any allergy from any medication?
No.
Any previous admission in the hospital?
No.
Any family history of any mental illness or epilepsy?
No.
Do you smoke?
Sometimes.
Okay. And do you drink alcohol?
Yeah, socially.
Okay. And what are you doing for a living?
I'm working in a company. I'm secretary.
Okay. You came today with a case of fall. So what do you think is the cause of this fall?
Doctor, I'm always fit and well. I have no clue what could be. I'm very shocked about. I'm worried.
Okay, and so from what you have told me today, that you have a case of a fall, we think the most probably from epilepsy. Have you heard before about this?
No.
It's a condition of abnormal activity in your brain that cause abnormal movement in your body. Am I clear for you?
Okay. Yes, I understand.
So we need now to do scanning in your brain to check for any abnormality and connect electrodes to your scalp to check for tracing in your brain. What do you think about this?
Okay.
We are going to ask for neurology consultation to assess your condition. Is it okay for you?
Okay.
So, do you have any other questions or concerns in your mind?
No.
Okay. Thank you.
Yeah. Good. You didn't cover the systemic review. Doctor, what's your name?
Muhammad.
Yeah, Muhammad, you forget to cover systemic review, and the IC should cover it after systemic review. Then you go for the past medical history, and you forget to summarize. Okay, so you need to you need to work on it. Another thing, this can be epilepsy, it can be psychogenic non-epileptic seizure. Both can be present with the same feature nearly. So you can say that it can be likely, it can be this one, but I need to rule out. About the EEG, you don't have to do. You need to do the full blood count, heart tracing. Okay, ECG. These all things. Yeah, first you need to say it's most likely the epilepsy or the psychogenic non-epileptic seizure. In medical term, we say. What I'm going to do, I want to keep you here in observation room. I will do the examination, neurological examination, okay? Okay, your brain, the nerves, the sensation of your body, okay? Because this examination should be done, right? Okay, examination, don't forget. Examination you will do for all patients. Examination, then what you will do, the investigation, what full blood count, the CT or the MRI heads, okay? Maybe it can be to rule out the overgrowth or any mass in your head, you can say like that. And I will refer you to neurologist for further assessment, for further investigation, which include EEG in medical terms. That means the neurologist, the specialist doctor will add a device on your scalp, and then it will check the electrical activity of your brain. If found abnormal, that would confirm the epilepsy. If it's normal came up, that means it's likely you have psychogenic epileptic non-epileptic seizure. You need to say like that, okay? So it means you need to.
I need to say it may be epilepsy or non-epileptic.
You need to say the both. But it can the differentiate will only possible in EEG. EEG, you come normal with the non-epileptic seizure, okay? It's abnormal with the epilepsy. Clear?
Yeah.
And then you say the neurologist will give you further drugs or medication. What else? It's all in his hand. Okay. Okay. Well done.
Advice for DFLA, doctor.
Yes. Advice you should add,
Advice
of course.
also.
Yes. Very good. Advice you will aid it. Yeah. Muhammad.
So in the history, I should ask about the driving, or you drive any car or work in the car?
You don't need to ask about that. And 38-year-old in UK, of
But
course, she must have a driving
how
license.
how I advise her to not drive if she not drive if she don't have a car?
Bear in your mind, in the EU, in European Union,
Yeah.
most all the people have the driving license in young age.
Okay.
So you
Yeah.
just assume that and you just follow the guideline and advice. Does she drive or not drive is not our issue. Clear?
Yeah. Okay.
Yeah, you just need to follow. You just need to fight for your score to pass the exam.
Yeah. Yeah.
Okay, so let's see who is the next one, guys. Any other candidate?
Dr. B, I have question.
Oh, okay. What's your question?
Okay, about what is it? The person who is acting with me in this station. I want to know if when I ask a question, he will reply very soon, or he will delay like some seconds, because and now when we are asking you, yeah,
yeah, yes,
you take like some seconds to reply. So because time is running, right?
Yeah, problem is that it depends on how sick is the actor and how actor it is. So I'm very bad actor. Anyway, so the actor usually in London or all the examination of the RChem always talkative. Okay, don't think like that the actor will be not talkative. The way of the talk may be different. Maybe patient really pretend to have a pain like me. I'm sometimes try to really pretend to have the problem. And sometimes because the actors are really professional in the exam, most of them. It depends which place you're having. In London, yeah, they are professional. They talk very means fluently and yeah, not like me for sure. So it depends. So don't take me as a serious, maybe the actor really like me. No. You will have better actor because I am not a real actor. I even don't, very, very different. The actor which you will have, he might have practiced already 2-3 times with the doctor. Then they come up to you for the exam. Otherwise, the actor can forget many things, right? So it's not possible. You will have the professional one and you will not have any trouble like that, which you're having here. Okay.
Thank you.
Okay, so next doctor wants to practice. I don't know what's her name. Could you please tell me your name? Okay. Seema. Okay, let's come up to the station.
Just 1 minute, doctor.
Okay.
Okay. Okay. Good evening. I'm Dr. Seema Sraj, ED registrar. Can I know your name and age, please?
Yeah, I am Niron. I'm 32.
Nice to meet you. Hello?
Yes, thank you.
I have been asked to take some data from you. Is that okay with you?
Okay.
Anyone attend with you?
No, I'm okay. Anyone if, yeah.
So how can I help you today?
Yeah, doctor, I was walking today around 2 miles and I don't know what's happened. I feel dizziness. I feel it seems like I'm exhausted.
Yeah. Sorry for that. You have a bed now? You are comfortable?
I'm okay.
Okay. So can you tell me more about your complaint?
Yeah, after too much I work and I feel dizzy and I just like I went full and I feel like heart rate is really racing fast. I feel also a little bit sweating. I wet myself. Yeah.
Sorry for that. When did it happen?
Yeah, today in the afternoon.
Okay. Still you have heart racing?
I feel okay. I don't know. I'm not
So
sure.
just I need to, okay, I need to check your vital signs.
Okay.
And I will do heart racing to you. I will move you to results area. Is that okay?
Okay.
You tell me you are walking before that?
Yeah, I'm very good, fine, healthy.
Okay. Did you feel chest pain?
No chest pain.
Shortness of breath?
Yeah, I struggle little bit to breathe.
Any headache?
No.
Any vision problem?
No.
Did you feel any abnormal sensation in your limb?
No.
Yeah, good. Did you lose your consciousness?
I would say yeah. I can say not really.
For how? For how long?
I cannot exactly say, maybe few seconds, not very long.
Any witness with you?
Yeah, my best friend.
So your friend, he tell you if you have a jerk movement?
No.
Any tongue beating?
No.
Did you wet yourself?
You ask me, doctor, no.
Okay, didn't ask, okay. After that, you get by yourself or with assistant?
I got by myself, yeah.
Okay. You feel confused or you recover fully?
No, I'm okay. After that, I was.
Did you, okay. Did you throw out?
No.
Any change in your urine?
No.
Any rash in your skin?
No.
Any skin changes?
No.
Okay. So did you have any any past medical history?
No. I'm quite healthy.
Any past surgical history?
No.
Did you are taking any drugs?
No.
In your family, you have any disease run in your family?
Yeah, my dad has passed away at 40.
I'm sorry for that. Any sudden deaths in your family?
Yeah, knew any other than my father.
Just your father? Sudden deaths. Okay, sorry for that. So let us summarize. You feel when you are walking, so just you feel heart racing and you feel sweaty. Is that right?
Yeah, dizzy too. That's correct.
Okay. What is your concern?
I'm worried maybe I am going to have a heart attack like my dad.
Okay, I appreciate your concern. Did you want to add anything?
No.
So, according to your data, I want to examine you. I will bet already we shift you to restless area, so I want to examine you. I will examine your heart, your chest. Also, I will do heart racing. I want to do some blood tests like random blood sugar. I will do urea and electrolyte also, and I will check your vital signs, blood pressure. So. Okay, this is your ECG, heart racing. So sorry to tell that you have, according to your heart racing, you have a syndrome we call the Brugada syndrome. So this is a congenital disease we run in your family. You are understanding me?
Yeah.
Okay. So I want to consult a cardiologist about that, and this is a serious problem. It can cause a sudden cardiac death. So you need to follow with a cardiologist, and as I tell you, and he will put a definitive management to you, like a small device will insert in your chest, so it regulates your heart beating. Is that okay?
Okay.
You are understanding me? You want to
Yeah.
add anything?
No.
Thank you.
Okay, so guys, you follow the systemic review. Okay, good. ICU didn't complete ICU. There are 3 questions which are totally relevant to this kind of. This is very important. ICE. Are you worried about something? Okay. What's your concern? This is all the same. Okay. What do you expect from us? It's all very important question. So another is about the, just like you found this ECG. So it's a good news or the bad news, guys?
Bad news.
We found
Good news, because you found that the patient has Brugada, now you can treat, and so it's a good news.
Bad news for the patient.
Yeah, it's a bad news for the patient. So how will you say to patient? How will you explain? But you need to explain a little bit the way it's real time. Like, unfortunately, unfortunately, I'm sorry to tell you that the ECG shows a condition called Brugada. But there is not nothing to worry, because there are a few things which need to be sorted out, and there is no total cure about this disease, but there are a few things which we need to follow. First, you need to advise about if you have temperature, you need to control temperature with paracetamol. Keep hydrate yourself, because these are the triggers to further increase your heartbeat. Okay. And also avoid emotional stress which you're having, and for that you need to take help from occupational therapists in case you have it. It will help you to avoid from fasted heartbeat or EDC, just like that. So about the treatment, in severe cases, you need to mention like that. If your heartbeat is very fast, or you can say in severe cases, we have a treatment. We insert a small device. You need to tell him, we insert a small device in beneath your collarbone, that when your heartbeat is very fast, it will give a shock and to normalize it. For that, I need to refer you to cardiologist. Note the way you say you found Brugada and you said it's a serious condition, I'm going to refer you to the cardiologist. So it's not a good management plan. Better to tell the things which advice you can give in the ED, because these things you can tell, right? The rest of things will be done by cardiologists, which things the job do by the cardiologist, not done by ED physician. You need to refer. The things you can do, you need to verbalize, and also, if possible, tell the cardiologist treatment. Sometimes what happened, the patient, the actor would like to ask you, doctor, what is ICD? They would ask you this question. Sometimes when you ask, do you have any question? They want to know the treatment for what you're referring. If you don't know the treatment, that means you're losing your score. Sometimes even they ask you what medication, doctor, you will give. What medication or what treatment, why do you refer me to the fall clinic? Then you need to explain, okay, you said I refer you to the fall clinic. but you don't know what the fall clinic work, what is the job of a fall clinic, you will lose your score. Because if you do not give the answer to the patient, what he's asking, that means you're losing your score. Because Mrcem asked this patient to ask you this question, to test your knowledge, how far you go. So if you do not give the management plan, and you do not tell the referral for what you're referring and what is the full clinic specialist will do, then you will lose almost 5. 3, no one gets 100% score, believe me. If someone said you will get 10 out of 10, this is just like, it's not possible. Usually the maximum came up 9, okay? But it depends on how is your management plan, how is your approach. So anyway, so you should remember, you refer to gum clinic for what? You need to highlight. You refer to the fork clinic for what? You need to tell. And better to explain. As much you give explanation, if you have time, that much score you can gain. That means you are professional. That means you real-time encounter those patients. But if you just say, I refer you, the Mrcem will think like, maybe you haven't encountered this patient in real time. Osce means practical, means real time. So you need to prove that you know these things. So be ready. Patient can ask you a question anytime, can stop you anywhere. Even they can ask you about antibiotic. What antibiotic you're going to do? Give me how many times a day. Be ready for it. The Osce is nightmare if you just go over. You will be likely fail. So better to go in deeper to understand more things and follow the guidelines. Don't need to follow Dr. B. Dr. B never says something from his own word. Dr. B tell you everything about the management. This come from the guideline. I never say anything which has come from my own mind or own creation, and I don't follow the guidelines which are using other than the UK. So I will never ask you to do even to. Okay, so let's come up to the next station. Let's see if we have it. Okay,
Dr.
no
B,
more,
if same patient, he asked me,
no more
if same
station.
patient,
Yeah.
if same patient, this Brugadis patient, he asked me if I'm gonna to die, what I will answer the patient.
Of course, you will show him empathy. Okay, you don't need to say, of course, no, you will not say like, yeah, you will die. No, or I'm sorry to hear that. We will go for it. It's sometimes it's not really the cause of what you think. It can be another cause. For what we have to run some blood tests, we need to heart tracing. Then I can confirm you what is the cause of your condition. Anyway, if there is even a Brugada, we have a treatment for that. Means you don't need to. You need to make the patient calm. Okay. Suppose the patient.
Mm-hmm.
Do not stay with the negative. Your job is to show empathy, support the patient, and give the treatment plan. But when you break the bad news, this is the bad news to Brugada syndrome confirmation. So you can break in a way that the patient feel that you feel the same way, you are with him. Okay, not like suddenly you jump up, you just say, oh, your ECG show you have Brugada syndrome. Okay, we have this treatment, we have no. Unfortunately, I'm very sorry to say that the ECG, the heart racing cam, it's confirmed that you have this problem. But there is not really nothing to worry about it. We have a good treatment management plan for that. If you follow it, it will be all right. This way you can support this patient. Clear? Any question, guys? This was our last station, but remember that what we discussed in this station can come to you vasovagal, can come to you orthostatic, can come to you heart block. It's not necessary what we discussed this station will likely come like this way, can come like this way, can come in different station, but you should remember these are the commonest symptoms in syncope, like vasovagal, orthostatic. These are the can be patient have the arrhythmias, likely the heart block, can be Brugada, can be another one. So you should be ready for all the scenario. The fall clinic is multifactorial. Any patient come with the fall, you give the first aid, the treatment. If he injured himself, you need to treat that injury, and then you need to assess follow the assessment scale or assessment screening tool, okay, for the fall, and then you refer to fall clinic. Not like the way we use. I see some candidate ask me previously that how do I manage this? So remember, the full multifactorial, you need to do screening tools, examination you have to do if it's relevant, and then you refer to the fall clinic. Any question?
Dr. B, what is the role of antiarrhythmic drug in Brugada syndrome?
There is, according to guideline, the British Heart Association, there is even no the drugs. They didn't mention antiarrhythmic drug in it. Okay, but there is found somewhere the beta blocker, etc. But I think you don't have to mention that. You just need to mention avoid the triggers. Not every the Brugada syndrome patient really need the cardiac defibrillator. Not every patient. Some patients need a monitoring and the follow-up. Not every patient really need ICD. This is, if you learn it, this is wrong way you learn it. Clear?
Yes, sir.
Any other questions?
I would like to say, Dr. B, it was an amazing session. We learned a lot, and it was a very nice, structured, and very constructive session. Thank you so much for your time and your efforts.
I'm doing
Yes,
all my
thank you.
I'm doing all my best to correct you guys, because I am already aware of that many of guys going the wrong way. And that is the one of the reason that even the guys know the station they are fail. The failure is due to their wrong management plan. The people are not doing their job to give the treatment, just jump up to refer. When you are doing so, that means you are losing your scope.